Alright, I wanted to go over some information before we went and saw our next patient and treat him. So he is a 20-year-old male. He came to our rehab center following a traumatic cervical spinal cord injury due to a skiing accident. His official medical diagnosis is an incomplete spinal cord injury at the level of C7. So some other issues that he's been presenting with is orthostatic hypertension. He's a weak functional cough. He is unable to ambulate. He has a stage 1 wound on his right heel, spasticity in his bilateral hip flexors, and incontinent bowels. So some other information to note is that he had an ORIF to decompress and stabilize the fracture site utilizing right iliac bone graft. So he will be in a Philadelphia collar. Some other important information is to note that he lives with his parents. He is attending community college to complete his business degree. He's working part-time as a car mechanic, and he is hoping to get married in October. So some other important information from his assessment is, he does have orthostatic hypertension. He has no active contraction below C7. What he does have is he has bilateral triceps and biceps, wrist extensors, flexors, and finger extension, but he has no finger flexion. So, and he also, his skin integrity is absent below T4. So, it's like we noted before, he is incontinent bowels, he has increased spasticity of bilateral hip flexor, and his ankle dorsiflexion is in 5 degrees from neutral. So, looking at his functional mobility, he is a moderate assist for bed mobility from rolling right to left. From supine to short sit, he requires maximal assistance, and the same is for long sit. So for his transfers to wheelchair, so from bed to wheelchair, he's a max assist, and from wheelchair to toilet is a max assist. And he is using a transfer board. For his self-care, he requires a max assist for dressing himself and for his upper body, and he's completely dependent for dressing of the lower body. So bathing, he's completely dependent. Feeding, he's mod assist with, he is using some adaptive utensils, and the same is for grooming. He's mat assist with some adaptive utensils. And his toileting, he is a max assist. So his communication, he is alert, he's oriented, he's able to follow commands. So he knows where he is and what time it is, and and he's aware of his situation, and he is very oriented. One thing to know is he lives with his parents in a split level home. So next we're going to go on to what our treatment plan is for today. So some limitations and activities. He can't be mobile in his home, and he has problems with short sitting and the wheelchair. So one thing to note is he has low tolerance for sitting in his wheelchair. He can only do it for about a minute. So what are the reasons for his lack of mobility? Well, he has no contraction below C7. He has no trunk contraction, and he lacks sensation. So what is our intervention going to be? So we're hoping to do some rolling to the left and to right using momentum technique to teach him to be able to swing his arm across his body to provide some momentum. And we're going to also be using the invisible dog to help him cross his leg over in the direction he wants to roll. And so next would be, well, how are we going to treat his short sitting intolerance? So that is probably due to some lack of contraction of his trunk and his orthostatic hypertension. So for that, we're going to be doing some static and dynamic postural balance with some weight shifting and stabilizing reversals. And with his static, we're just going to have him sit there for about a minute and see how he is. So he just needs to be able to do it more and build up that tolerance. So why did I choose to address bed mobility? So I wanted to, he needed to be able to improve his independence and his ADLs and self-care, because if he isn't able to move himself back and forth in bed, he's not going to be able to set himself up for other transfers. And this will allow him to start gaining some independence on his own. And also it's going to be able to help him reposition himself so that he won't have skin breakdown and get pressure ulcers. So why did I also pick the short sitting? So for that one, I wanted to increase his wheelchair tolerance and static balance and his dynamic postural balance, because one big thing is he will be in his wheelchair a lot, and especially as he's learning to use it. And if he's out in the community, he's going to be in it, so he needs to be able to tolerate more than a minute, especially if he wants to be a student. He's going to be sitting through classes that are going to be quite long. So, and then this will also help him with his ADLs if he's needing to sit and groom himself and fix himself food and all that. He needs to be able to tolerate sitting for a lot longer than 1 minute. So that's kind of where we're at with our treatment, and now let's go and see our patient.